I'm delighted to now introduce our next speaker, Dr. Sarah Cullum. Thanks so much for being here today, Sarah. Sarah Cullum is an associate professor in psychological medicine at the University of Auckland and a consultant in old age psychiatry at Counties Manukau in Auckland, New Zealand. She has over 20 years of clinical and research experience in dementia, and she has led research on the epidemiology of dementia in Aotearoa, New Zealand, assessed ethnic disparities in access to care, and co-developed a website to support carers in taking care of themselves and their family members living with dementia. Sarah is currently an Atlantic Fellow at the Global Brain Health Institute here in Trinity College Dublin. Today she will speak about research and related activities in the LiDiA programme, which describes the extent and impact of dementia in New Zealand's major ethnic groups. The floor is yours, Sarah. Thank you.
Okay, can you see my slides and hear me?
Yeah.
Good, great. Thank you for inviting me along here today. So as you can hear, I'm not Kiwi, I'm from the UK. But what I want to do is to describe my journey over the last 10 years. And because that reflects the journey of our dementia research in Aotearoa, New Zealand. And I just want to start with this template slide here, which is from the University of Auckland, and the lovely carving that you see on the right is actually from the prow of a waka, which is a traditional canoe, and it's very spiritually meaningful for Māori because a waka is about teamwork, because you've got everybody paddling in the boat, collaboration, and obviously getting somewhere, and I think that's quite relevant to our journey in New Zealand. So just a little bit about me. Oh, now why didn't that move forward? Can you see the next slide? Yeah, good. So in all public sector meetings, we introduce ourselves with our pipiha or whakapapa, which I'm going to say now just because I think you might be interested in it. So it's my genealogy is ko Blackheath te Monga, ko Thames te Awa, no London Aho, ko Sarah Cullum tōku ingoa. And what I'm doing is I'm announcing myself not by my name first. In fact, that came last. I announce myself by my mountain and my river and what I identify with. So the first photo here is actually Greenwich Park. Blackheath is my mountain. It's not a mountain, but it was to me as a kid. And Thames is my river, which is at the bottom of Greenwich Park. So from there, I went to Leeds University, and there's a picture of LGI there. Went into psychiatry and then ended up in Cambridge at the Institute of Public Health, which is this East Forvey building. And I did my PhD there in epidemiology. And this is why I approached dementia research in Aotearoa the way I did. So I was under the supervision of Carol Brain there, who's a famous dementia epidemiologist. Then I ended up in Bristol, and I did 10 years clinical there with some research in the background. And after that, I moved to Aotearoa, New Zealand in 2016. So the ethnic makeup is 68% Pakeha, which is European origin, Māori 8%, Asian 17%, and most of those are from China or India. And then Pacific Islanders make up the last. Can I just check that you can see, because I haven't got black boxes over my slides, have I?
No, we can see it perfectly.
Oh, good, because I've got boxes over my slides, so I'm just going to move them. So yeah. So quite different to what I was used to in Bristol. So I started out working in Middlemore Hospital, which is in South Auckland, which is a very diverse area. I mean, I would say less than 50% of the population is European. We had a high Pacific Island population, mostly from Samoa, Tonga, Fiji, and the Cook Islands. All different, although they're Pacific Islands, they don't like being lumped together because they're all different countries, different cultures, different languages. So that makes life very interesting. I worked at the memory service there, and what I noticed was, well, the first thing I noticed was we used a lot of interpreters, probably a third of our referrals, we took an interpreter along. And when we made dementia diagnoses, there was very little culturally appropriate services to be able to refer people to if they weren't, white European. So the services were very Eurocentric at that time. So I did some networking when I first got there and found out what was going on. First thing I did as an epidemiologist was look to see if there had been a dementia prevalence study, and there hadn't. What there was going on was quite a lot of biomedical lab-based research. There was also a new dementia prevention research clinic opening up, and the director was Lynette Tippett, who's in that picture. And that was to get cohorts of people with mild cognitive impairment, deeply phenotype them. They're about the only people that do get PET scans and blood-based biomarkers and so on, and then follow them up. Alongside that was a large study by Macarena Dudley, who is a Māori dementia researcher, and she was traveling up and down the country talking to kaumatua, who are the kind of old elders, about what they thought dementia was, what they felt about it, and what needed to be done. And one of the things that they often said was that they didn't like the cognitive tests that were done during the dementia assessment. They found them humiliating. They felt like they were school tests and so on. And in fact, they looked at the mini mental state examination and actually found that Māori got diagnosed, if you just use the MMSE, more often than Europeans. But if you actually did a proper diagnostic assessment, they didn't. So MMSE was culturally biased and scoring them lower. So in fact, what's happened since then is they have produced a Māori-friendly cognitive tool called the Mana tool, the Māori Assessment of Neuropsychological Abilities. But Mana also means pride in the Māori language. And that is now being rolled out, which is great. So this was the backdrop for me. I did look into whether ethnic differences might be expected due to modifiable risk factors, and found that, sure enough, on the left here, obesity is much higher for Pacific and Māori than European and Asian, which is a risk factor. The mean age of stroke in New Zealand for Māori is 10 years younger, the first stroke, than New Zealand European, which I think indicates the risk factor profile. And then this last slide down here on the bottom right is actually diabetes. And what it shows is that the Indian population and Pacific population have a very high prevalence of diabetes. Like by the age of 70 to 75, it's 50%. And we would see that in our memory service. And a lot of it not controlled well either. So that's another risk factor. So we then thought, well, let's look at our data in the memory service, which had been running since 2013, and we had about 4 years worth of data. And I had a neuropsychologist working in the clinic who was very good at collecting all this data. So we thought, right, we're going to have a look at this because there's nothing else. So even though it's not a perfect sample, we want to see what we can find. So the question was, do community-dwelling Māori and Pacific peoples present with dementia at a younger age and at a later stage compared to New Zealand Europeans? And sure enough, we found that they did. So in this table, you'll see that the mean age for Māori and Pacific is up to 8 years younger than New Zealand Europeans. And we don't think this is just because life expectancy is less, because we see a lot of people coming through the clinic. But obviously that's a flaw because this is just a clinic sample. We also found that Māori and Pacific most live alone less often than New Zealand Europeans, particularly Pacific. They're 7.6%. And this is through cultural choice. They live in multi-generational households. It would be very unusual for an older person to be living alone. And again, the comorbidity score was higher for Māori and Pacific, as we suspected. So this was giving some evidence of what we saw anecdotally. And just to say that the Pacific Islanders often do present later. This happens in other health disorders as well. They not so much for Māori, but Pacific Islanders tended to present in the kind of moderate stage of dementia rather than the early stages. So then we thought we were going to put together a group which we called LiDiA, Living with Dementia in Aotearoa. And what we did was we found researchers who were interested in this area from the main ethnic groups so that we could actually build up a multi-ethnic community-based dementia prevalence study. And to do that, we needed to have a dementia assessment tool which we could adapt for different languages and cultures because most people spoke their native language. So we invited Martin Prince over, who's sitting there in the back there, and we adapted the protocol for Māori, Samoan, Tongan, Fijian Hindi and Hindi. And then we already had a Chinese version and an English version. So we spent a couple of years just doing working with expert advisory groups, adapting, testing it out, validating in the memory service. So that took quite a while. And then we also, as I said, had different research leads. So the research lead for the Chinese community was Gary Chung, who's an academic old age psychiatrist in Auckland. Rita Krishnamurti led the Indian group. She's an epidemiologist, mostly in stroke epidemiology, but is moving into dementia. And then Tony Katoki and Fiva Farlow are Samoan and Tongan researchers. So we started to kind of build capacity within our group. But then we also, we got lay interviewers. So we did lived experience of dementia qualitative research. And to do that, we had to have bilingual, bicultural interviewers. So we started training people up who were interested. They were mostly kind of graduates to do the interviews. Then we realized we needed them to do the analyses as well, because we didn't want to translate everything into English. So they got trained up in doing the thematic analyses. And I think we've published 3 of the groups, and the Tongan one is about to come out. So we're kind of capacity building all the time. In 2019, we were awarded $500,000 for the feasibility study for the New Zealand dementia prevalence study in those groups that I mentioned. Adrian Martinez Ruiz came over from Mexico. He had already worked partly in the 1066 study. That's him with the glasses on in the middle. And who's a lovely man. And I think this is why this study worked, because he got on with everyone, whatever ethnic group background they came from. They went out door knocking together. They had, went out together in the evenings and so on. So he really created this kind of joyous community, if you like. And we managed to get the feasibility study started, but then 2020 happened. And although we managed to, we had 0 cases for about 9 months, we weren't allowed to do any interviewing in people's homes or whatever to keep people safe, especially older people safe. So we had to put everything on hold for a while. But being resourceful, we decided we'd look at other ways of doing things. And in New Zealand, we have this really good national data set, integrated data set called the LiDiA, which integrates data and links data from health, justice, housing, education, social services. And it's all linked by the National Health Index, which is like the NHS number. And so what we were able to do is we thought we'll look at this data set and, a bit like Nahid was saying, define what is a dementia diagnosis. These are only people who've been identified and diagnosed and coded, but we thought we'd give it a go. And sure enough, we found with this that the prevalence using this method was higher for Māori and Pacific at the age of 60 and at the age of 80 compared to Asian and European. And, this was almost twice as high. So again, another piece of evidence. It's got flaws in it, but, it helped us to build this kind of case around disparities in dementia. We also looked at inequities in dementia. So using the same methods, we're actually able to look at what spending there had been on community care and aged residential care. And if you put the 2 together, you can see that on the left-hand side there, on the right, on the blue one, the spend on Europeans was almost twice what it was for Asian. And this is mostly because Asian and also Māori and Pacific don't tend to use aged residential care, but they don't get the kind of the increased community care that they might need if they're looking after their family members at home. So this was great because we're starting to get some leverage with our data now that we can really show that there's an inequity in New Zealand, and that's something, even if it's a cultural choice to keep people at home, we need to be thinking about how do we spend public resources to support people staying at home. So then I'm just jumping ahead a few years, but because one of the things we also thought about was we can learn from people who keep people at home, people with dementia at home. How do they manage? You know, we went into people's homes and people are managing really well. So what is it that they do, and how do they manage? How do they flourish? So we got a program grant this time for 5 million to look at these issues in Pakeha, that's the European, Chinese, Indian, Maori, and Pacific populations. And the objectives were to do a dementia prevalence study. That wasn't done in the Pacific populations because actually it wasn't feasible because people didn't want us coming into their houses, and partly because the protocol, when somebody comes into your house, before you can even start the interview, would take about an hour and a half. And people didn't have that kind of time, you know, they need to get to their work or whatever. So they didn't want people coming into the houses, even though we had interviewers from the same ethnic groups. And we're looking at how we're going to get around that, probably with churches. So as well as that, we want to do the prevalence study. We want to look at the diagnostic accuracy of the routinely collected data that I talked about that we used. We also want to look at the costs of dementia and the trajectories forward, and particularly in the Pacific groups and Asian groups, what is the cost to the family? So not just the public sector cost. We want to look at how people manage, what are their successes and strengths, and ultimately start co-creating solutions using ethnic-specific project planning models, but within the scarce healthcare resources. So that's going to be over the next 4 years now. So and so there's a parallel study led by a Maori researcher, that's Macarena Dudley, and that's going to be a dementia prevalence study. And Fiva Farlow is that she's not doing a prevalence study, but she's really doing Macarena's previous study, which is what is dementia, what does it mean, how do you manage it? So all of those are going to dovetail into each other once we have all the data. Meanwhile, we're also developing a carer support package, because obviously you need to have some post-diagnostic support, and that's not very good for the non-European groups in New Zealand. So we've tried to create a online support package using the WHO iSupport for dementia, which is a generic manual that can be adapted for different countries, a bit like the 1066. And that's been led by Tara Sunny, who's from Indonesia, and Hemi Fanga, who's a Maori researcher from Masi. And we've just got to the point where we can launch that for public use. Itu Mao is also an academic old age psychiatrist doing his PhD, and who's worked with Nahid on the dementia prevention, particularly looking at the difference in risk across different ethnic groups. And you probably can't see that, but for example, the risk factor, the risk for Maori and Pacific is much higher due to obesity than it is for Asian and European, where hearing loss is a bigger factor. And there's lots of other things, but I'm not going to go through those in the interest of time. We've also started looking at linking data to try and detect dementia from electronic health records. And in counties Manukau, we have been able to link all the data that you get in the national data sets, but also delirium data, because we screen for delirium in all the over 70s, I think, in the hospital. It's not full coverage, but it's useful. And then we've put these in one data set and applied deep learning models to predict who might have dementia. So you train the model and then you test it. And we found the accuracy was about 80%. We did a sub-study as well where we added in CT scans and that increased the accuracy, but we were only able to do that in 200 rather than 16,000 or whatever the previous sample was. And of course, we would like to be able to do this on a national level. You could use it to start detecting dementia, but that would take you into population screening, which has a lot of ethical issues. So we probably won't be doing that anytime soon. So what next? I think it's a global conversation about digital diagnostics because not only do we need culturally fair tools, which are a lot more likely to be digital tools, but we also need them because there is a shortage of specialists, and that's going to get much, much worse, particularly in low-income countries. I mean, for example, in Nigeria, I think there's 70 neurologists for a population of 230 million. So we need to be thinking about how do we disseminate skills. So how can we get non-specialists to be using some of these tools with the support of specialists, but not having the specialist actually having to do the face-to-face work unless absolutely necessary. And then we're also going to develop the caregiver support. I'd like to kind of get that into an app rather than a website and make it more friendly. And we've tried to make it multicultural, but it's still in English. So it needs a lot more work. And then we're going to the prevention and optimizing brain health throughout the life course. Throughout all of this, we will be looking at equity. And I think one of our strengths is that we have built a great team, which is very multi-ethnic and is kind of going off into different directions now, which is exactly what it should do. So we're not necessarily all working on the same thing, but the work is developing elsewhere. And of course, partnership, co-producing research and working with the ethnic groups who are actually so happy that this work is being done and that they're being interviewed in their own languages. So there's a lot of support for this work where we thought there might not be. So I think that kind of brings me back to where I started, which is this waka. I feel like we've built a fantastic waka. We're all paddling along and we're going to get to our destination. This is the group, or some of them. We took this picture, I think it was December 2020, when we were allowed to mingle, just to make you jealous. And I won't name everyone. And thank you for listening.